welcome to everyone who's joining this call this evening, and welcome on behalf of the College of Medicine. We are all delighted that George has given his time to come and talk to us this evening, and I look forward to a most informative talk. George, thank you so much. I'm going to mute everybody who may not be muted already, and then hold on, there's a couple more coming in. And then at the end, we'll take some questions. Oh, here we go. So to all those who've just joined, a great welcome. And George is now going to start. Thank you very much indeed.
Thank you, Sarah. Thank you for asking me to do this, and also thank you for sharing it. It is an honor, and I'm grateful to you and to Amanda for having given this opportunity. So we are going to talk on can exercise decrease the need for total hip and total knee replacements? Now, just to give you a background, I am George Ampat. I'm an orthopedic surgeon. Though I say I'm an orthopedic surgeon, I mean, when you see a QR code, you will see a few QR codes here and there. And if you put your phones on it, you will be able to get the link. This is the link to my website, nothing else. But there are other QR codes also. Though I'm an orthopedic surgeon, I am slightly a different type of orthopedic surgeon because I believe that we should not be doing too much of surgeries and also not too many tablets also. Because 5 tablets in the morning, 5 tablets in the afternoon, 5 tablets at night, does it actually benefit the sufferer of the problem, or does it benefit the shareholder of the company that makes the tablets? I don't know. So we got to be very careful. And what we need to be doing is actually improving people's health and not making them take pills or potions or, or even have surgery when it is not needed. And we must understand that nature made us after millions of years of research. So nature is better. Just because I've been to medical school and I've done a few years of surgery doesn't make me anything better than nature. So we need to, exploit whatever naturally we can get better before we resort to any intervention. So hopefully we have 7 objectives today. So the 7 things, are what is osteoarthritis? What are the treatments for osteoarthritis? And then the myth of overusage. Then we'll talk a little bit on abuse, the real cause. And abuse could be underuse or extreme use, and we'll come to that. And then we'll come to exercise programs to treat osteoarthritis. And we'll look at some of the real world evidence of reductions in pain following exercise, and what is the last, and that's the main part of the topic. How can we decrease the need for surgery? What is the percentage? What does the evidence show? And what should we do for that? And hopefully there are some take-home points, or at least, pointers for you to help you in your day-to-day practice. So what is osteoarthritis? Now, we all think osteoarthritis is just a problem of the end of the cartilage. There are different types of cartilage. In the ear, we have elastic cartilage. There is also fibrocartilage. That is when you damage, elastic or hyaline cartilage. But the cartilage in the end of bone is a specialized type of cartilage, and it's called hyaline cartilage. The advantage of the hyaline cartilage is that it is a very smooth surface, allows gliding over the other, and it's quite frictionless, maybe one of the most frictionless objects that can be found on Earth. The advantage is it not alone is it shiny, but is also absorbent of water. And when it squeezes, the water comes out, and that way it gives you a lubrication, or the synovial fluid leaks out and gives a lubrication for the joint to move. But it doesn't have nerve or blood supply. So unless there is movement, it doesn't get nourishment. If it stays still, there is no nourishment for the hyaline cartilage. So unless the joint has to move, and when the joint moves, the synovial fluid moves from place to place, and that is what gives the nourishment to the hyaline cartilage. And also, because it is so specialized, it is only given to us once by nature. It is not given a second time. So if there is damage to it, it doesn't have the ability to regenerate. Yes, it will regenerate, but that is fibrocartilage and not as good as hyaline cartilage. Hyaline cartilage is such specialized cells and such specialized tissue. Now, when we talk of osteoarthritis on the, if as you look on the image, the left of the image is a good, or a joint, whereas on the right of the image is where there is osteoarthritis. Now, we should not just assume that osteoarthritis is just on the top of the cartilage. It is a disease of the whole bone. So there is problem, I mean, the bone and the joint. There is damage to the bone, there are subchondral cysts, there is hypertrophy of the synovium. The synovium is the lining. So when two bones meet, there is a sleeve of tissue that holds both the ends of the bone together. And there is a lining, and that lining is the synovium. There is hypertrophy, means the cells in the synovium are increased. The capsule or the outer sleeve that holds the two bones together, that is thickened. There is damage to the cartilage. There is new blood vessels that are grown as if there is some inflammation there. Sometimes even nerves go there, and that is how we experience pain. So it is not just assuming that the outer layer or just the cartilage is gone. It is the entire bone and all its components that make the joint is damaged in osteoarthritis. So it is a complete, it's an organ failure, not just the surface of the organ that is damaged. And cartilage itself is very specialized. You have three layers of this hyaline cartilage. So if you look at the image on the right, you can see the top fibers run parallel to the surface of the cartilage. So that gives it a lot of tensile strength. So even if you're moving it, shearing it, it doesn't get damaged. So that is why the fibers are the top. In the middle, you have intermediate fibers. But down at the bottom where it meets the bone, the fibers are now perpendicular so that it increases the compressive force. You can take the compression on it and the cartilage is not destroyed. So each layer has a specialized function to it. And this is the way we classify osteoarthritis. This is the by X-ray, one of the ways you can classify it. So the Kellegren and Lawrence, that is what is generally used. So on the extreme left, you can see a grade 1 where there may be some osteophytes. Osteophytes is the excess piece of bone that grows at the ends of the bones as you have osteoarthritis. You can see another osteophyte here. You can see some osteophytes here. There is no loss of cartilage. Here you can see there is some loss of cartilage. The ends of the bones are coming together, but still there is some cartilage. Now it is very close to each other, but still there is some little amount of cartilage left. But in grade 4, it is now bone on bone. So the characteristics of osteoarthritis is that you will have osteophyte formation. There will be loss of joint space. There sometimes may be cysts. Can't see any, there may be, these could be a little cyst here. And also osteosclerosis. Osteosclerosis means the X-ray looks white in color. If you see this one, it looks light gray, but here there is severe osteoarthritis and you can see it becomes whiter. That is osteosclerosis. And those are the features of osteoarthritis. So those are the 4 X-ray features of osteoarthritis. Now, what are do you really need an X-ray to identify osteoarthritis? No, we really don't need an X-ray. You see whether there are risk factors and clinical examination. And obviously, if the patient has pain and symptoms, you can diagnose osteoarthritis even before you need an X-ray. An X-ray is only ideally required if you're thinking of any other intervention other than say thinking of an operative intervention. That's the only reason why you may need an X-ray. This is the X-ray of a hip, and there is a lifetime. Now, times that the chance of osteoarthritis in the hip is less than of the knee. There's more risk to have an osteoarthritis of the knee rather than of the hip. And this is the lifetime risk of a hip OA. And you can see on the right side, you can see a good cartilage. So you can see the ball and the socket. And the area in between is the cartilage. And you can see a nice, good layer of cartilage between the ball or the head of the femur and the acetabulum of the socket. Whereas on this side, and on this side, you will see that you can see the ball and you can see the socket. But here you can see the ball and the socket are coming together and there is loss of cartilage. So there is one of the signs of osteoarthritis. Now here it is a CT scan of CT
Right,
scan.
thank you.
CT scan of the hip, and you can see that again the cartilage is lost. And not alone is the cartilage lost, I don't know whether all of you can see, little cysts are formed. One of the origins of the cyst is the synovial fluid goes and makes small cavities in the bone, and that is how these cysts are formed. And again, that is a sign of osteoarthritis. And you can see on both sides here, there is loss of cartilage space. This is in the knee, an X-ray. In the knee, when you're taking an X-ray, ideally you want a weight-bearing X-ray while you're standing and putting weight through the leg. And the inner side of the knee is usually more likely to fail than the outer side of the knee. So osteoarthritis is mainly on the inside. When you have rheumatoid arthritis, it's usually on the outside rather than on the inside. And here you can see on both the inside, it's like bone on bone and there is no cartilage. On the outside, there is cartilage. But this doesn't mean that though it is bone on bone, we can't treat it. We can only treat it with an operation. This can be treated by exercises, and we'll look at the evidence as we go along this evening. Now, the next thing is, what are the treatments available for osteoarthritis? There are many treatments available, not one. Now, if you look, this is a fantastic by Smetzland. They did a systematic review of all the treatments available to osteoarthritis, and they only looked at the entire literature, and they looked at all treatments which had a randomized controlled trial. So some form of treatment which has been included as a randomized controlled trial, they have listed that. And they have come up with a total list of 156 treatments for osteoarthritis. So it's not one. What it shows is that no treatments work. If there is a single treatment that will work, there wouldn't have been a second treatment. Everyone follow one treatment. When now there are failures with all treatments, that is why you have such a large number of treatments. And that is why we have 156 different treatments according to this systematic review. And they give all this list of the tablets, combined, control, corticosteroids, diet, exercise, herbs, intra-articular injections, mind and body exercise, non-steroidal anti-inflammatories, opioid, orthotics, passive treatment, regenerative medicine, surgery, symptomatic slow-acting drugs. All these are potential treatments for osteoarthritis. And they look at the different evidence and which comparison is more. And when they look at all the randomized controlled trials that they had looked at, they found the greatest number of trials to come between exercise and control. So control being the placebo and exercise being the main form of treatment. There are other treatments. You can see the weightage of each line tells you how many trials. So between, say, exercise and passive treatment, the weightage is less, whereas diet, loss, weight, and control, this is the weightage. So according to the thickness, that is how they have made this sort of diagram to make us understand the different comparisons of the randomized controlled trials. But then there are guidance. There are guidance in America, there is guidance in UK, and also there is guidance by the osteoarthritis. We look at some of the guidance. I won't go too much detailed into them. But the UK one, I'll slightly go into. This is the American College of Rheumatology, their guidance. And again, if you look at their guidance, so they have given for the hand, knee, and hip, that the guidance is together for these three. So they are first, where there's physical, psychological, or mind-body approaches, it is exercise, self-efficacy and self-management programs, weight loss, Tai Chi, using a walking stick. For the knee, they suggest a brace. But if you're looking at medicines, they say oral non-steroidal, topical non-steroidal, sometimes intra-articular steroids using X-ray, or paracetamol, tramadol. These are the different medications they suggest. But they also suggest what should not be used. And among the things that they say we should not use strongly against is TENS machine or bisphosphonates, glucosamine, hydroxychloroquine, methotrexate, tumor necrosis factor inhibitors, interleukin receptor antagonists, platelet-rich plasma, stem cell, chondroitin sulfate, intraarticular hyaluronic acid. So these are the things that they recommend that should not be used, or strongly against or conditionally against. Then there is an international organization called the Osteoarthritis Research Society International. They also give some guidance. They divide it between knee osteoarthritis and hip osteoarthritis. Not a lot of difference. But in the knee osteoarthritis, they say education, structured land-based exercise programs, strengthening and or cardio, balance training, neuromuscular exercises, mind-body exercise, including Tai Chi or yoga, with or without dietary management. That's for the knee osteoarthritis. And for hip arthritis, something similar, arthritis education, structured land-based exercise programs, strengthening or cardio or balance training or neuromuscular exercises. But what happens in the UK? So we had an initial guidance, but then it was updated in the guidance, the nicest guidance 226. It was updated in 2022. Now, that guidance is a lot of literature, but the good thing is BMJ has given a nice pictorial summary of this guidance, and I will pick out a little bit from them. So here you can see there are, both non-pharmacological management and pharmacological management. So pharmacological management includes topical NSAIDs, oral NSAIDs, non-steroidal anti-inflammatory. Don't just give paracetamol alone. Don't give weak opioids. Don't offer strong opioids. Don't offer glucosamine. No intra-articular hyaluronic acid. And don't offer acupuncture or dry needling. But the most important is what we see here, where they are saying that as emphasis on non-pharmacological management, reserving medicines only for short-term management. And the short-term management to give them pain relief so that they can do the exercises. Exercises is the key. So that is what you can see here in the non-pharmacological. The first and the foremost is exercise. And what they are now saying, the orange is the new upgraded guidelines, where they are saying that the exercise should be combined with an education program. So if you just give exercises, people are not going to be compliant. If there are 100 patients of mine, I give them a tablet, 70 of them will take the tablet. But if there are 100 patients of mine, when I tell them to do exercise, only 30 of them do the exercise. So what we need to find out is how can we make exercise more palatable? How can we inspire patients to do exercise? Because it's sometimes very difficult. Even I want to walk every day, but there are many days I don't walk. I mean, life comes in the way, we are busy, and then we may not do the things that, which will make us better, like exercising. The next thing they suggest is weight management, trying to lose weight. But it is not just the weight. I think we need the muscle power. So even if you're slightly overweight, it's okay, as long as we have the muscle power to support ourselves. But even a little bit of weight loss is okay. The next I want to visit is the myth of overuse. Because we all think, oh, you're running, you're a runner, you're a marathon runner, you're likely to get arthritis. That is not the case. If you run, there is no evidence that it can increase the chance of arthritis. So it is wrong. So what are the myths and truths about hip and knee osteoarthritis? The myths are the degree of OA predicts pain and disability. No, that is wrong. Pain equals damage is wrong. Exercise is dangerous is wrong. Rest is helpful is wrong. So what are the truths about osteoarthritis? Scans are poorly related to pain. You can see bone on bone, but they may not have any pain. Equally, you can see someone with no loss of cartilage and they are in severe pain. And pain doesn't mean that there is damage. Pain can occur without damage. We can go through this a bit later if you want, because that is a separate topic. The next thing is exercise is safe and it helps. And the worst thing that we find now is patients come with arthritis. They come to the hospital. The doctor or the surgeon tells them, you need a hip replacement or a knee replacement. Then I'm just using the name Dorothy. Dorothy goes home, sits and doesn't move because she thinks she's due for a hip replacement or knee replacement. And when she's sitting and not moving, the muscles waste and the pain becomes worse. It is important that we are exercising and moving because otherwise the muscles become weak. Even if you are having an operation, to have strong muscles is essential because if you have strong muscles, your rehabilitation after the operation is better. So to improve the strength of the muscles is very vital. Yeah. And some very good work has been done by this lady. Her name is Eliza Chakravarti. She's from Stanford in US. And she did an amazing research. This was over a 21-year period. So this started in 1984 and ended in 2005. And during that period, what she did is she took about 1,000 people, 500 were runners and 500 were non-runners. And she compared the two groups over this entire 21-year period. And both these groups were people over the age of 50. So people over the age of 50, ordinary community dwellers who were not running, the other group were people who were running. And what did she find? The bottom line, the pink line, are the runners. This line over here are the non-runners. You can see the disability, how the disability keeps on increasing year after year. This is in 1984. This is in 2004. Over more than a 21-year period, you can see the disability of the non-runners are increasing much more than the disability of runners. And this is what is called as postponement of disability, which means if you are a runner, for you to become so disabled, it takes you more than 12 years. So if a non-runner is disabled at the age of 60, the runner is only disabled at the age of 72. You're postponing your disability by 12 years just by gentle running. That is the advantage of running. That is what she identified. And more importantly, how we are dying. If you look at this is the survival statistic, and you can see that if you're running, you're not dying, you're living long, you have a healthy long life. But if you don't run, you are dying quickly. And that is this graph showing. So exercise and running, and this is over a period of 20 to 21 years that she has charted. It is impossible to do such a long time study, and that is what she has done. Again, part of that same study by Chakravarti, she looked at long distance running and knee osteoarthritis. And here you can see people in a runners club and people in the community. This is not full 21 years, this is only about 18 years. What we are seeing here is the amount of arthritis on X-ray, prevalent radiographic OA. So in the running club, initially, they had slightly more, people who were running had slightly more arthritis. But at the end of 12 years, that 6.7% had increased only to 20% of runners had arthritis. Whereas if you were not running and ordinary community controls, it was 0% at the beginning, but within that same 12-year period, it had become, 18-year period, it become 32. So if you're not running, the chance of developing arthritis increases. That is this part of that same subgroup analysis. This is again a systematic review by Dillon et al. And in this, coming from Colorado, so they've taken all the evidence that were there in running and osteoarthritis and they have put them together. And what does this evidence show? So they had huge numbers. So here you can see there were 7,000 runners in total and 7,100 runners and 6,900 non-runners. And you can see the BMI of the non-runners are slightly chunkier than the runners. But then what is very important is the amount of arthritis they have. If you have a runner, again over a long period, the chance of arthritis is only 28%. If you're a non-runner, the chance of arthritis is 41%. So it's quite high, at least 1/3 more high if you're a non-runner compared to a runner. So it is a complete myth. So someone who runs a marathon, who runs daily in the evening, yes, they may be pounding their joints, but that is not causing harm to them. That is what all this research is showing. So it is not causing any harm. It is advantageous and protective. So then how do we get osteoarthritis? If running is not the cause of osteoarthritis, what is the cause of osteoarthritis? Now, we have sometimes wrong terminology. So, and the next few slides, if you're an animal lover or you like animals, maybe you want to close your ears and eyes for the next couple of slides. It may be slightly traumatic for you if you're an animal lover. So, it should be only 3 or 4 slides. So Herzog, he was from Canada. He did some excellent research. What was his research? Sorry about this. It's not very pleasant. So he took these cute New Zealand white rabbits. And what he did to those rabbits was on one leg, he injected Botox. So in the thigh muscle of the rabbit, he injected Botox, and the other leg he left alone. So one thigh of the rabbit cannot move because he had injected Botox, and the other thigh he didn't do that. And at the end of a month, he would sacrifice the rabbits. And these were the specimens from 4 different rabbits where there was no Botox, and you can see the muscles are quite big. Within a month, look at how shriveled the muscle becomes. So even a month of weakness. But that is not because this we would know, because you inject Botox, the muscle becomes weak. But his research was not about what happens to the muscle, what happens to the cartilage. So this was where there was no Botox given. Muscle is normal, muscle looks good. And the cartilage in the knee was also good. But the rabbits who had Botox injection into their thigh, their muscles become weak. You can see so much fat is infiltrated in the muscle fibers are gone. And what has happened to the cartilage? Here the cartilage is nice and smooth, but here the cartilage is completely damaged, even as short as 4 weeks. This is a microscopic view. But so the first thing, what this research shows, is it the chicken or the egg? It is not that the pain causes the weakness. There is first weakness in the muscle, and the weakness of the muscle is what drives your arthritis. I hope I made myself clear. It is not the pain that makes you weak. It is the weakness or the non-use of the muscle that actually drives the arthritis. So it's important to combat that weakness. And this is one of the specimens. So if you take a macroscopic specimen, you can look at the tibia. It's already reddened within just 4 weeks. Of 4 weeks of not weakening of the thigh muscle because of the increased stress, because of the increased shear forces that has happened. So it's a weakness that has led. So if the muscles are weak, there is an increased chance of arthritis. This is the study from Japan. There is a small district in Japan called Matsudai, and that is in the Niigata province of Tokamachi. And they have been doing serial X-rays and surveys. So previously it was done once in 7 years, and recently it has been done once in 3 years. So it started in 1979. You can see all those 1786, 93, 2000, and recently they've been doing in 2010, 13, 16. So they took a group from 2007 and a group from 2000. Some people have died, you must understand. It's over 40 years. So some of them naturally have passed away. So, but they took a group from 2007 and 2013, so 6 years. And what they did is, in 2007, when they came for the study, they measured their strength of their thigh. And then in that 6 years, how many of them developed arthritis? That is what they were looking at. And what did they find? So this is their research. They have reported that quadriceps muscle weakness is related to increased risk. So what did they find? So this, the top table is on the women and the bottom table is on men. So what they found, the group that developed arthritis in those 6 years among the women were 24%, and their quadriceps, the strength was weaker. So if the strength was higher, the chance of arthritis was less. Same way here, if your quadriceps strength is weak, there is more chances of you getting arthritis than if your quadriceps strength is strong. So it's a muscle weakness that comes, and then subsequent to that is what the arthritis develops. Metaphorically, it is very easy for us to understand. In my car tire, I need 40 pounds per square inch in my car tire. Now, if I put 40 pounds of square inch air, then the car drives well, the tire is fine, and when the tire drives well, there is no increased stress on the shock absorber. But if I don't inflate my car tires well and my tires are already half inflated, as I drive my car, then the car wobbles a lot. If it wobbles a lot, something has to absorb that wobbliness. And the only thing that will absorb the wobbliness is the shock absorber, and that is when the shock absorber will fail. So it is important that our car tires are well inflated. Similarly, our muscles need to be strong. Here on the left side, in the knee, the muscles are weak. And when the muscles are weak, there is constant shear in the cartilage. And when there is constant shear, there'll be arthritis. Whereas here, the muscles are strong. And when the muscles are strong, you can bend and twist and move. And there is no abnormal shear and the cartilage is maintained. Now, we talk of this thing called wear and tear. That is wrong. That is a wrong terminology to use, wear and tear. And I'll tell you why. Because in the human body, there is no wear and tear. And I'll tell you what is the term we need to use. Now, yes, if you are having inanimate objects, if you're having dead objects like a tire, like you look at this truck tire. Yes, on the left, it is new tires. On the right is old tires. Now, yes, this is pure wear and tear. It has no ability to get normal or regenerate. But that's not with the human body. In the knee, there is both a degeneration as well as a regeneration. As there is wear and tear, as there is wear, there is also repair. It is not that the wear is only happening one way, but it's a two-way direction. The body heals. So if this is in your car, you have got a damage in your car, it doesn't naturally get better. But we know that this wound on the knee will naturally get better. You may put a plaster or a band-aid on it, but this wound will naturally get better because the human body has the power to regenerate. The human body has the power to heal itself, so it is able to heal up itself. But the tire cannot. The car, damage, the dent in the car cannot, but the human body can. So it's inside the human body, it's a two-way process. There is degeneration, there is also regeneration, and that is what we need to. But then you may have more degeneration than regeneration. So if you are using a very heavy load, then it is beyond the ability of the body to repair itself. And when it is beyond the ability of the body to repair itself, so here you can see the arrow, there is more degeneration than what can repair itself. That is when you can have damage. So yes, if you're running, you will not get a problem. But if you're playing football and high-level competitive games, then you are likely to develop osteoarthritis, but not if you're just normally running. So healthy loading is good. Healthy loading is good because if you're running or doing such activity, as you move the knee, you're lubricating the joint moves through its motion, the synovial fluid is bathing the end of the cartilage, it is nourishing the cartilage, and there is nowhere, damage to the cartilage. So it is good, and the loading is a healthy loading. So yes, this is also unhealthy. Here you're not loading, you're just sitting and watching TV. When you do that, yes, there will be the normal degeneration, but there is hardly any regeneration. There is no repair process. The repair process can only occur when the muscles are working, when there is blood flowing, and that is the only way the cartilage can repair itself. But if you just sit, and one of us just sits and watch TV, there is no way there is regeneration. So there are two issues. So we know on the left, a little wound like this, the body has the ability to heal itself. But obviously, if there is a big damage like this, obviously we need attention. So normal running, normal activity is good. It is protective. It is good. But abnormal overloading, like in elite football players, or if you have an injury, then a great injury, then obviously it may need attention. And that is when you develop osteoarthritis. So ideally, instead of using the term wear and tear inside the human body, we should say the term wear and repair. Yes, if the wear is more like if you're a football player, or if the repair is not good because you're sitting idle, that is when you will have osteoarthritis. Whereas in a normal joint where you're normal, what our ancestors were doing, if for millions of years, nature made us over millions of years. So whatever our ancestors were doing, if we do that, it is unlikely for us to cause a problem. It is when you do abnormal, either sitting too much or extreme activity, that is when we have a problem. This is some research done in Sweden. There are not just in Sweden, there are other places also similar research has been done. In Sweden, what they did is they looked at all the Olympic people who had been to Olympics in different games and compared them with age-matched individuals and found if once you're in a high competitive sports, so normal sports, nothing happens. It's only high competitive professional players have a problem. So here, if you're a high competitor, and then they looked at controls. So if you're an athlete and a professional athlete, then the chances of osteoarthritis is 29%, whereas in a control it was only 18%. And the chance of having a hip or knee, replacement, if you're a Premier League athlete, then it's 11.4% compared to the control of 5.8. So if you're an elite athlete playing high level games, cutting and turning, yes. But if you're a low level running or just normal, five-a-side football, there is no risk at all. So what are there exercise programs to treat OA, osteoarthritis? There are. I've identified about 7 programs. This is not an exhaustive list. There are more programs than what is I have identified. So these are the 7 programs. The Escape Pain from UK. There is a Nuffield Health Joint Pain Program in the UK again. In Denmark, this is the program I like most, the one in Denmark. It is called Good Life with Osteoarthritis in Denmark, GLAD. And they have actually both Canada, Germany, and Australia have taken on this GLAD program. That is GLAD Australia, which is given to all patients there. Then there is Better Life with Osteoarthritis Goa program in Sweden. Then hip and knee training in Germany. Then in Norway, you have the Active with Osteoarthritis Activa. And in New Zealand, you have the Otago exercise program. These are all exercise programs. Now, looking at one of these programs, so this is the Escape Pain from UK, which is a London-based program. And this is the brainchild of Professor Michael Hurley. So he's in St. George's. He was in UCL, and then I think he moved to St. George's in 2010. And he's the clinical director of NHS England on musculoskeletal program. And he has published extensively. This is one of the articles that he has published. So in this Escape Pain program, participants are invited to attend 12 sessions over a 6-week period, twice a week, a 1-hour session. The 1-hour session involves a 15 to 20-minute discussion. And following that, there is a 35 to 40-minute exercises, which is individualized for each participant. That is what the 1-hour session involves. And some of the sessions are like this. You can, it is a sit stand. This is one good exercise and also a good test for anyone who is a senior, because ideally we should be able to achieve about 25 to 30 sit stands within a minute. Younger people may be able to achieve greater, but ideally this is me doing the exercises. All my exercise videos, you can find the pudgy me doing the exercise rather than a lean, mean fighting figure. So if I can do the exercise, anyone else can do the exercise also. So this is a sit stand, is one of the programs in Escape Pain. Or they also do about proprioception. So what I'm doing here is writing the alphabets with the foot. And this improves the joint position sense of proprioception. Joint position sense is the way the joints are, the body needs to know. Because when I land my left foot on the floor, the messages go from my left foot to my brain telling how the ground is. And based on that knowledge, the brain lands my right foot, and that is how my balance improves. Unfortunately, in osteoarthritis, what happens is we lose that ability. And to regain that ability to do this exercise will improve our proprioception. So any strength training should be linked also with some joint position sense training or proprioception. So in this particular study, they used the WOMAC, or the Western Ontario and McMaster University Arthritis Index. And you can see that with Escape Pain, so what is in baseline after 6 weeks and after 30 weeks, 30 months, baseline 6 weeks and 30 months. So the pain was similar, But as soon as they have the escape pain program, within 6 weeks, the pain has dropped from 7.5 to 5.2. Yes, it slowly creeps up at 30 months, but it's still less than what you if you were doing no exercise at all. So this program shows that it is good, beneficial, decreases pain, and people are maintaining that. Now, if you like to follow the escape pain program, they have a very good website. And escape pain is enabling self-management and coping with arthritic pain using exercises. This QR code should lead you. If you have your camera, you can take this QR code, and that will lead you to the escape pain program. They also have an app, and you can get their app on their website. So this is about their app that they have. It is a completely free program, but it is rolled out in few centers, but not in a lot of centers. Now, again, this is a recent publication by the same group, and what they have shown is they have rolled out this into the community, and that is what they are seeing. So nearly about 1,492 people were treated with this escape pain program, and it improved their pain, quality of life, mental well-being, physical function. And before the program, only 24% were active. But after the program, 78%, they inspired 78% because the group classes are far better. Yes, there was some decrease in 6 months, but still 69%. And what they estimated by just doing this program, the saving per participant was about 326 pounds. And the important thing is they found their exercise program was delivered by exercise professionals in the community, not by physiotherapists in the hospital. And they found that it is as good as doing physiotherapists in the hospital. So it is important that we are moving away from the classical medical model, the illness model, hospital, clinics, from hospitals. We need to be moving into gymnasium. We need to, from the spectrum of illness, we need to move to the spectrum of wellness, where we are going into gyms, going into community centers, meeting with others, and then exercising. Meeting with others helps, because Dorothy, inspires Graham, Graham inspires Donald, Donald inspires Annie, and that is how it works. So doing group exercises is very beneficial. We'll also look at some of the real world reductions in pain with exercise. So this is some work done in Canada. And this is a very small study, but it shows very clearly how if you leave people alone, they become worse. This is a very small, not a big study. There are 3 small groups, only about 11 to 12 patients in each group. So this was the no treatment, whereas here was a face-to-face treatment, and here was through the telephone, internet, there was pre-rehabilitation. And what that showed is, even if you have tele-prehabilitation, they are improving. This is the in-person. And here, very importantly, their pain decreases. But here, if you leave them, their pain increases. I know the amount of decrease is less. From 8.1 pain, it becomes decreases only to 7.8. Not a significant amount. But if you just leave them alone, they become weak and their pain increases. So it is very important we are not allowing people to just rest at home when they are on the waiting list. We need to be actively managing our waiting list. We need to be giving them exercises, because otherwise they are becoming worse. Their operation is not going to be, good, and they are going to have more complications. So we should not be keeping them, idle. This is Grace Lowe, and she's a rheumatologist in Houston, Texas. And she has also done some amazing work in osteoarthritis, and again, how exercise helps. This is part of the National Institute of Health. There's something called the NIAMS. There is a National Institute of Arthritis and Musculoskeletal and Skin Diseases under the National Institute of Health in the US. And they had what is known as the osteoarthritis, just like what I told you about Japan. They had an osteoarthritis initiative over a 13-year period. They were annually taking X-rays, blood samples, and also private companies were involved in this. And anyone can actually write and ask, scientists can ask for data, and they will give us the data. So Grace has done some work. So this is on strength training and how strength training helps with osteoarthritis. So this is again a questionnaire survey. So if you have done some strength training, the chance of getting radiological, that is X-ray proven osteoarthritis, if you've done strength training, is 53. If you have not done any strength training, it is 60%. So it's increased. And the amount of exposure of strength training, if you have done high, it reduces even further. If you've done moderate, it is a little bit less. So it shows that more amount of strength training decreases your chance of radiological, that is on X-ray osteoarthritis. Again, this is symptomatic. SOA means symptomatic, that is you have pain. Again, if you've been exposed to weight training, the chance of you developing symptomatic osteoarthritis is only 23%, whereas if you have not been exposed, then the chance of getting osteoarthritis is 29%. Similarly, there was some work done on this is done from again US, again Grace. This is on walking. Is walking beneficial? And that is what she's looking at. So if you're a non-walker, then the chance of osteoarthritis is 37, whereas if you're a walker, it is 26. If you look at the X-rays, if you're a walker, the chance of 18%. If you're a non-walker, it is greater. So throughout, it is showing that by exercise, the effect of arthritis and pain is decreased. I don't want to repeatedly say the same thing, but again, this is the work from Denmark, and they showed how, again, repeated exercises, there was exercises plus an education program, and just an education program alone, but with exercise and education program, the pain improved. Whereas if you just do the education program alone, the pain decreased. So you need both the exercise and the education program alone. So where is the evidence that it actually decreases surgery? We don't have a lot of evidence, but there is some evidence that it decreases the need for surgery. Now, surgery, we do this quite a lot. Recently, we had the 20th anniversary of the National Joint Registry. And so we have a lot of procedures done in our country. This is only the UK. And we have totally, over the 20-year period, we have recorded about 3.5 million procedures in the UK. Out of 3.5 million, 1.4 million of hips, 1.5 million of knees, 8,000 ankles, 8,900 elbows, and 63,000 shoulder replacements have been done. And you can see year on year how the number of replacements, this is on hip replacements. So just 20, you can see 2020, the numbers are low. That's because of the pandemic. But just before the pandemic, we were hitting about 90,000 total hip replacements in a year. And slowly after the pandemic, we are catching up. Similarly, you can see the different types of hip replacements. You can see the decrease of cemented hip replacements, slightly increase of uncemented, but then there is a further decrease, some hybrid replacements. This is on knee replacements. We do more knee replacements than hip replacements. We do about 110,000 knee replacements. Again, there is a dip for the pandemic, and after the pandemic, we are slowly catching up about knee replacements. Majority of knee replacements are the classical cemented knee replacement, but there are few uncemented, few hybrid, unicondylar, and patellofemoral. Now, this is excellent study, and this is from Denmark. I told you where the GLAD, Good Life with Osteoarthritis in Denmark. This is Skov et al. Skov, he is Professor Skov. He has done wonderful work, and he developed the GLAD program, and that's a Denmark-based program, and they have rolled it out into Canada and Australia. And that they did some, so this is their research on total knee replacements. So these were patients who were bad that they required surgery. So this is in the tertiary center. That is, they have come and seen an orthopedic surgeon, and the orthopedic surgeon says, yes, your knee is bad, you need a knee replacement. So 100 of those patients were taken and randomized into two groups. One group had the knee replacement and exercises, but the other group only had exercises and non-surgical treatment. It's not just exercise. They also gave them an orthotic, and some educational, input also was there. And what they found, the data, they got 43 people who had surgery, not the total knee replacement, and 47 non-surgical treatment. And importantly, let's leave the data on the top. Don't look at the data on the top. Look at the bottom. At the 47 data they had, out of the 47 people who orthopedic surgeons said they required a knee replacement, Only 16 required a knee replacement. 31 said, well, actually, after doing the exercise, my knee is better. I don't need a knee operation. So 62% of the patients who had osteoarthritis of the knee and who the orthopedic surgeon said may require a knee replacement did not require. So the average is, even after the orthopedic surgeon says you need a knee replacement, if you do the right exercises, then there is a 60% chance you can get away without having a knee replacement by just doing these exercises. This is the same group's Cow et al. About hip replacements. This is the wider group, only part of it is relevant to us. There's totally about 4,000 patients here, 3,657. But 100 of those participants were waitlisted for total hip replacement. But during that period, only 60% required the procedure for a 2-year period. That they said, we don't need a hip replacement now, the exercise making us better. So 40%, so same, that is 40% didn't require, only 60 required. So in knee replacements, if you do exercise, there's a chance that 60% will not need a knee replacement. And in hip replacements, if you do exercise, 40%. This is after the orthopedic surgeon has seen it. This is slightly different research, again from Denmark. But here the patients are not yet listed for surgery. But this is over a 6-year period they have done this research. And these are patients who have some arthritis, but not bad enough for hip or knee replacement. So they have taken those patients and followed them up over a 6-year period and seen how many of them will finally require a knee replacement in that 6-year period. And what they found, that out of the people, 2 groups of people who were allotted and not allotted, and they found that in the people who had done the exercise, only 22 required a total hip replacement, whereas if you didn't do the exercise, 31. So there are about 9 people who have been saved, of the group of about 50, about 18% or 30, have been saved without requiring a total hip replacement by doing the exercises. So just to recap what we said today, it's like my car tire. If it needs 40 psi, the shock absorber survives well. But if I don't inflate it well and I underinflate it, then there is increased wobbliness, increased shear, and increased stress on the shock absorber, and it will fail. Same way in my joint, if the muscles are strong like on the right, then there is no shear, it bends well, it moves synchronously. But on the left, as with the muscles are weak, then as we move, there is a shear forces created. The shear forces can damage the cartilage and increase the chance of osteoarthritis. We very commonly use the word wear and tear, but is that the right word to use? Yes, in an inanimate object, there's only wear and tear. There is no repair, because tires like this can only go one way. It cannot become better. But that's not with the human joint. It's a two-way. There is degeneration as well as there is regeneration. Car, if it is damaged like this, it doesn't get better naturally. But a small wound like this gets better even if you don't put a plaster. The body has the power. Nature has the power to heal. So we are an animate object or a live object, and there's a two-way process. But the two-way process has to be helped by movement. But if you do too much, like a heavy load or, a professional footballer, then there is obviously greater amount of degeneration, greater amount of injury, and likely to have damage. But what if you healthily load it, then is unlikely and is actually protective and makes the joint healthier. If one sits and watches television, there is no movement, so there is no possibility for regeneration. So we need adequate movement for the blood supply to go, for the synovial fluid. So a little wound, a small injury, the body can repair. A big damage, like a professional footballer, then obviously, that is overloading and we need to do something. Ideally, what we need to do, what happens in the human body is not wear and tear, but wear and repair. But how do we get our patients to, how do we motivate them, inspire them? I'll end you with, hopefully a pleasant thought or something very funny. So men think, they are very, because they have organ, they have good at aiming, but actually men have a poor aim. And this was the research done in Netherlands, and they found Netherlands airport, and they found that men using urinals and they had more, the cost of cleaning the men's urinal was greater than the cost of cleaning the women's urinal. And they were surprised, and especially when men have something to aim and shoot. And then they found the men were using a telephone, and while they were urinating, and hence they were peeing all over the place. Now, how did they improve the men's aim? They did a very clever thing. They took all their urinals and put an inverted fly on the urinal. As soon as they had the inverted fly, the men forgot their phones. They were now focusing on the inverted fly and making that as a target. So the cleaning costs in Netherlands airport decreased by 70 to 80%. So that inverted fly was what motivated people to have a better aim. And we need that inverted fly to get our patients to exercise. Now, what do I do to help my patients exercise? This is me. Last year, I was fortunate enough, me and my wife, fortunate enough to be awarded the best teacher of the year in University of Liverpool. So how do I do that being a good teacher? The only thing I do is I inspire my students. I tell them they're amazing, they're very good, they're excellent, they're legends, and that way they inspire, they do well. Same way I tell my patients, oh, you're awesome, you're amazing, you will do well. I have every faith in you. One word I always tell my patients, I will stand with you in your journey. We will go together. And that inspires them, and potentially they do the exercises. Now, this is again on the QR code. You can find a lot of my exercises. Again, I'm doing the exercise if you don't mind watching me. And all these are recognized, research methods of exercise. So if you go to myselfhelp.org.uk, you can find these exercises. Thank you very much. I would like a feedback. So if you have a mobile phone, you can point at this QR code. It will take you to the feedback page. But if you don't have a mobile phone, you can type in https://bit.ly/AmpatTeach. If you don't have that, I will anyway be sending you an email, and you can fill it. There will be a link on that email, and you can fill it up. Whichever is convenient for you. So and I open the forum for any questions. Thank you, Sarah. You're muted, Sarah, I think. Yeah. Sarah, you're muted.
Thank you very much indeed. That was really interesting, and I very inspiring, and gives us some very good ideas for the future. So if everybody has taken the link down, perhaps you could stop sharing your screen, and then we can see people and see whether they're putting their hands up. Thank you. So if you would like to ask a question, you're very welcome. David Binder, please unmute yourself and ask a question.
Hello, thank you, George. That was amazing.
Thank you, thank you.
I've actually written down 6 questions, but I'll just ask one for now, and then I'll come back to the others later.
Yeah.
Now I do a hell of a lot of cycling, so I cycle far more than I walk. Is the one more important than the other? Is it just a case of moving? Because I also do some bespoke exercises for my hip, but my main exercise, I would say 85–90% cycling, 10% walking. Does that matter?
No, it's very good. Cycling is very good.
Right. Because with all the pain I had last year, I never had any problems when I was cycling. It was just walking, because when I'm cycling, I'm not weight bearing, so it wasn't a problem.
Yeah, but that's okay, but in cycling also you're taking the synovial fluid around the joint, you're nourishing the hyaline cartilage. Is very good. Yeah.
Brilliant, thank you. I'll come back to the others after and give others a chance.
Sure.
Right. Now we have someone else who has raised their hand. Who is that? Would you like to unmute yourself and speak and introduce yourself? Hello, Sue.
Hello, and thank you very much, George, for a fascinating webinar. It's really related to the previous question, I think. I was so interested in the research that you quoted, and a lot, if not all of it, was comparing runners with control groups or community controls. And I was wondering, Is that comparing runners with people that don't do anything or with other forms of exercise?
No, it was runners with who were not exercising at all, not other forms of exercise.
Okay,
They
so
had
other,
to, yes, it is not runners versus swimmers or runners versus cyclists. Any form of exercise is okay.
so
I've concentrated more on running because of the, there is this effect. People have this myth that when you run, you're pounding repeatedly and going to damage your joint. That is why I concentrated on running. And the control groups everywhere in the running were people who were not actually doing any form of exercise.
Okay, perfect. Right, that's great. Thanks very much.
No, that's okay.
Our next question is from our Zoom user. Would you like to introduce yourself?
Oh, hi there. Hi, George. I'm
Hello there.
Ken, a GP in urgent care. So thank you
Thank
very much for the very excellent presentation that you made. You've made osteoarthritis a very much easier to understand topic by the way you explained it. So yeah, I'm also glad to hear what you said about injecting the joint space with hyaluronic acid. So that was one thing that I got asked a lot by patients, actually, and stem cells as well. So I'm glad to hear from you that there's no evidence to support that. And then even things like taking glucosamine, that was really popular at one time, I think still is for some people. So what about turmeric is the other thing that I would like to ask. And then the other question is about, with the exercise programs, were there any people that were excluded from it? Like, for example, were there like certain categories of people that you felt weren't going to be able to do them, so they were naturally excluded?
Well, if there is no cardiac contraindication, there is no reason why one should not exercise. And it is, it's a relative, I mean, forgive me for saying what I'm going to say now. We'll all die at one point. So there is end of life. But the risk of dying with exercise is less than the risk of dying without doing exercise.
Sure. But what about those who say, I'm in too much pain, or, I'm just too big, too large to do any kind of exercising? Because some of the things that you were showing, like, sit to stand, some people can't even manage a couple of those. So what would you say to those?
Sure. So what I tell, so sit to stand is very difficult, and I accept that. And once you have lost that ability, it's very difficult to gain. So once they lose the sit to stand, I tell them knee bends. Now, knee bend is you stand up and you don't go fully down, just go 5 degrees down and up, 5 degrees down and up. By doing that, and what I tell them is the best time to exercise is the evening from 5 o'clock to 8 o'clock while you're watching TV. So every time you have a TV on and every time the adverts come up, stand up on your Zimmer frame, stand up straight and do just knee bends. Go just 5 degrees down, 5 times, sit down again. Next time adverts come, stand up, do those 5, then sit down, then stand up. Every 15 minutes, you do 5 like that. Today, you do little bit of bend. In a week's time, you're doing a bit more. In 4 weeks' time, you're doing a bit more. And surprisingly, if they maintain that, then they are doing a full sit stand within 2 to 3 months. So even if you're sitting and standing is very important, because as soon as you become, an older adult, you lose that ability, and we lose that ability to sit and stand. So to maintain sit and stand is very important.
So is there currently any program in the NHS that tailors it to the individual's kind of ability at the moment to do the exercise?
So the escape pain is good, but unfortunately, the NHS, we are not too keen on this. We like technology. We like to do hip replacements, knee replacements. We like the tablets. And sometimes, it's good that we are, 36 of us have come here. But all of us swimming is like we are swimming by the side of a cruise ship or a big ship, and we are trying to push the ship. All of us can't push the ship. That is the problem.
Okay, I get that.
So NHS is a big ship. It has got its path. Very difficult to change its path. But there is, it's not bad. People are thinking otherwise. And actually, the public are thinking otherwise. They want to change. They don't want needless surgery. Yes.
Any role for turmeric, the final
There
thing?
is definitely a role for turmeric. There is definitely, but again, if you are on any anticoagulants, you need to be careful with turmeric.
Yes.
But otherwise, turmeric is a very strong anti-inflammatory.
Any specific doses at all for it? Because there's so many
Well,
different formulations out
Yeah,
there these
I
days.
don't know whether all these formulations and what you come in tablet form is
Yeah.
good. I personally
In
believe
cooking.
cooking or when you
Cooking,
use it.
yeah.
Yeah. So I
Yeah.
tell my patients to take mix turmeric with milk and drink it like yeah I think in
Golden milk in India, they call it, isn't it?
yeah in
Yeah.
even in Pret Manger you get that, I think.
Oh, yeah, the
Yeah,
turmeric
you get a
lattes, yes.
turmeric latte. Yeah.
Thank you so much, George. You've
That's
been a
okay. Lovely
great
seeing.
wealth of resource. Thank you.
Thank you. Yeah.
Thank you.
So we have another 4 questions coming up. So the first one is Jane Emerson. Jane.
Yeah. Hello, George. Thank you very much for the talk. I found it very interesting.
Thank you, Jane.
I wondered if there was anything for the joints of the hands.
So people may get primary osteoarthritis of the hand. There are some exercises for the hand. The easiest advice I can give you is if you go on Amazon, you will find stress balls, and there are 5 rings. So I can't show you offhand, but if you go on Amazon and ask for hand exerciser, there are 5 rubber rings, and you have a connection between them, and you can extend and squeeze them. Same way you can use stress balls, and that provides you some relief. But what we must understand is musculoskeletal pain is episodic. Pain becomes worse for a few months or maybe for 6 months, and then it naturally gets better. Now, if I have come at the 5th month and I've just laid my hands on you and you get better, you think I'm amazing, but it's not me. It's just nature has done its job. So much of musculoskeletal pain is episodic. It gets better. Yeah.
Okay. Thank you very much.
Thank you, Jane. So Elliot, your turn.
Yeah, hi. Can you hear me?
Yeah, I can hear you. Yeah.
Thank you. Yeah, thanks very much for the presentation. It's been really good. Thank you.
Thank you.
Just wondered. I had an arthroscopy operation on my hip when I was about 5 years ago. When I was 40, I'm 45 now, and I just wondered if slightly off topic. I just wondered, like, are there any resources you recommend on what that means for me in terms of, obviously, the surgeon found that there was no it was just a joint on joint in my hip, and that's why he wanted to do the arthroscopy, to shave away some bone to stop the impingement, hip impingement. I just wondered, in terms of what I can do now to sort of get back to, obviously not to full strength, but I just wondered if you're aware of any sort of information out there on how I can sort of best recover. Obviously, I don't want to go back to the same surgeon because he'll want to give me a hip replacement at this point, because I've still got pain. Is it just a case of, just doing exercise, or, I mean?
Yeah, I think it's a question of doing exercises. I don't want to sound as if I'm giving what I don't want to move away from is giving you medical advice on the internet, because that would be wrong, because I have not even examined you. So I can give you some general pointers, but please note and make it clear that this is not any medical advice to you. I'm just giving you a general feedback. Exercises can help. If you can do any of the neuromuscular exercises, even some of the exercises which I told you on my, on the my self-help, those exercises are equally good, or even the escape pain exercises, or even if you go on the GLAD Australia website, they give all their exercises, and you can do any of those exercises, but you'll need a combination of exercises, proprioceptive exercises, strength building exercises, core exercises. It's a mixture of them that you need. Yeah.
So the exercise route. Yeah. Thank you. Okay. Obviously. Yeah. Yeah. Thanks very much again.
No, that's okay. Thank you. Thank you.
And our next question comes from
Louise. I'm Louise. Hello, George. Thank you so much for your talk. It's really interesting.
Thank you, Louise.
I just wanted to really comment on something you mentioned before about turmeric. And turmeric, the problem with turmeric is it's not absorbed very easily. And they do say that if you have it together with pepper, if you're going to use it in your foods a lot, if you have it together with pepper, the pepper will actually help the absorption of the turmeric. So it's really just a comment on that. And then further, I wanted to ask you your views of exercises like yoga, for instance, whether you think that's a good form of exercise for somebody with arthritis.
Definitely, definitely, because yoga has twofold effect. It's not just some patients with pain require, yes, exercises for the body, but some pain requires exercises for the brain also. There is a complete, I mean, I don't want to delve into that. There is a type of pain called nociplastic pain. And the advantage of yoga, it is not just an exercise for the body, it is also an exercise for the brain, because it gives you a lot of, meditation, relaxation, and that is why it is beneficial. Yes, yoga is very good.
Okay, thank you very much. Thank you.
Fine. Right, David, again.
Yeah, on to question 2. So it's kind of a 2-part question. I was curious about when you spoke about causes of osteoarthritis, because you brought up Botox as an example, but unless I missed it, I don't remember hearing about other causes or the main causes for people, because I've done a lot of exercise over my life. I've done a lot of tennis, used to do football, a lot of tennis and cycling. And the part 2 of this is I've had some Bowen therapy, which has really helped. And she reckoned, she was very confident that my osteoarthritis started, the process started back in 1985 when I broke my ankle. And she said, what a lot of hospitals don't do when you break your bone is they don't do a realignment. They just put your leg in plaster, and 6 weeks later, your plaster comes off. But they don't do any realignment. So she reckoned because of a weak ankle, I've been overcompensating in other areas, and it's the overcompensation that may have caused the problem. Would you agree with that?
That is quite possible, because sometimes when there is, you must understand, even if the biomechanics is altered by a small angle, that can increase the unnatural wear and tear. So traumatic injuries can result, and you're right, very right. But I don't know whether the realignment process, whether I don't subscribe to that. I just believe that you did better, strength training exercises, and that is why your pain got better. Yeah.
But what about other causes of osteoarthritis or main causes?
Correct. So osteoarthritis is a multifactorial disease. You must understand, like diabetes, it is a multifactorial disease. So there are genetics. Some people, unfortunately, their genes are not strong, their cartilage is weak. And if their collagen is weak, there's an increased chance of osteoarthritis. Then as I explained to you, the abuse. So the abuse can be an overuse or an underuse. So if, the classic example is the banker who works in a bank 5 days a week, and in the weekend he decides to do some gardening, and suddenly he hurts his back and he's got a disc prolapse. He thinks, oh, I just bent down and got a disc prolapse. Lifting was the problem. But actually, that was not the problem. Lifting was not the problem. He was sitting on a desk for 5 days and weakening his muscles, and there was sedentariness and sarcopenia. And you're not fit to lift a bag of sugar, and you go and lift a potted plant, you're going to hurt yourself. So it is a mismatch. If you're strong, then you can do it. So say for instance, I see a lot of patients, young patients, who go and do who say they have back pain, and they are in the gyms trying to lift weights. Then I tell them, okay, let's do a plank, a forward plank. That is, you're on your forearms. They can't do a forward plank, but they are in the gym trying to lift 50 kilograms, 70 kilograms. Unless your muscles are strong, how can you go and lift? And if your muscles are not strong and you go and lift, you're going to hurt yourself.
Mm-hmm.
Yeah.
Thank you. I've got a couple of other questions, Sarah. Am I okay to run through
one more, and then we'll see if anybody else has got one.
Sure. Okay. Okay. So obviously, exercise is the key here, and you've highlighted and magnified that tenfold on this call. But my question is, what if doing the exercise is actually causing pain? What then?
No, very true, very true, very true. So that is why I think little but often is important, and that is why the method I tell my clientele, my older clientele, or older adults, I tell them is 5 to 8 when you're watching TV. That is the best time to exercise, because if you do 5 repetitions, say for instance, quadriceps, hamstring, gluteus, just these 3, using weights, putting a 1 kilogram ankle weight, you put a 1 kilogram ankle weight, you sit in front of the TV. Every time the adverts come, do 5 quadriceps each leg, do 5 hamstrings on each leg, do 5 gluteus on each leg, sit down. 5 is not too much, you don't feel the pain. Another 15 minutes later, adverts come, you do the 5. So in an hour, you're doing 20 repetitions. If you sit for 3 hours, you're doing 60 repetitions. So if an older adult does 60 repetitions every day, in a month's time, his muscles are strong, his quadriceps is strong, his hamstrings are strong, his gluteus are strong. So little but often. The difficulty when you go to the gym, you have to be there for an hour and you have to exercise for 1 hour. That becomes difficult. Yeah. So,
okay. Thank you very much.
Pacing is the answer. Yeah.
Fine. I think we have a question from Sue.
Hi, thank you. Can arthritis be triggered? Can pre-existing arthritis be there but not known about, asymptomatic? And then can it be triggered by some form of injury? If so, I'm thinking of a situation whereby there was an injury in my hip, and almost overnight, it seemed to develop into osteoarthritis. If that's the case, can through exercise, etc., one get over the pain and revert to the previous situation where you can live with whatever osteoarthritis was there, but in a fairly asymptomatic manner?
Sure. Now, first of all, there are 2 types of arthritis, and we are only talking of osteoarthritis. There's also inflammatory arthritis. Inflammatory arthritis is like what you have in rheumatoid arthritis or gout or something like that. But today our talk was only based on osteoarthritis. Now, osteoarthritis is universal. And what I'm going to say next, please don't be offended by it. And especially the women shouldn't be offended by it. Because I tell my patients this, women put lotions and potions on their face. But even with their lotions and potions, the face shows their age. So if the skin shows your age, your spine, your hip will also show your age. It cannot be that you have a baby spine or a baby hip. So if you're 40 years of age or 50 years of age, your skin will show your age and your hip will show your age. So that is osteoarthritis. That is degeneration. All of us have degeneration. As soon as you're only a baby born today doesn't have degeneration, but a baby born yesterday has a 1-day-old degeneration. So slowly we are all degenerating. But in some people, there is accelerated. And there are many factors for the acceleration, as I explained. One is the collagen, your genetics, the amount of use or the abuse, you're not using it. And there is stress, shear because of the weakness of the muscle. There are multi-factors if you have had a previous injury. Now, in your case, I don't think that overnight injury brought about the osteoarthritis. It is like my kettle. It's been having a problem, but I'm still boiling water in it. Suddenly, tomorrow morning, it stops. It is not tonight was the problem. It has been happening, simmering over a period of time, and the last, straw that broke the camel's back. So yes, you were having arthritis, you were coping very well. There was some injury, and then you investigated, you found there was osteoarthritis, but you have done exercise and reverted, but you cannot undo some of the damage, some of the cartilage that is lost. You can't. What you can do is, even if the cartilage is lost, you can build the muscles up. So I tell my patients a metaphor. It's like, I lose my right arm. My right arm is my dominant arm. I lose my right arm. But even if I lose my right arm, now my left arm only does 5% of the task. If I start training my left arm, in a year's time, I can do a lot of work with my left arm. So even if the cartilage and bone is lost, if you build up the muscle, it is compensating for the loss of the cartilage and the bone. So the muscle is there. what happens is you have pain and they don't move. And when they don't move, the muscle becomes weak. So when you have arthritis, when you have pain, it is important to move the arthritis. It's important I use my left arm when my right arm is gone. And then I will potentially in a year's time, I can write with my left arm and maybe better handwriting than my right. I don't know, but it's possible. So same way, if the joint is gone, if you build up the muscles, then you're compensating for the loss.
Okay. And just to be absolutely clear on my part, once cartilage is damaged, thinned, gone, that's it. It cannot rebuild.
Yeah.
Yeah. Thank you.
No,
Thank
that's
you.
okay. Thank you. Yeah.
Yes, we have one question down here. Would you like to unmute?
Hermione?
Yes, we can hear you.
I just wanted to make an observation. One of the gentlemen was saying, well, what happens if people are in too much pain that they can't exercise? And I totally agree with George. You kind of start small and work up, and little bits add up to a lot. But you often find that people's soft tissues hurt when they have arthritis. It's not just the joint, it's kind of stuff around the joint. And so I often say, well, you know, I teach them how to massage and not be scared of really stimulating the circulation and shifting the tissues, you know, and I'll often sort of, you know, they can use whatever cream they like really, but, you know, and just help that way. And also ice is so fabulous. You know, I'm old. I've got more injuries than other people have had hot dinners, but I'm not in a wheelchair yet, you know, and these things really help, you know, as well as the strength training. And I think also what we overlook is the flexibility. And I agree with George about the yoga. I used to teach yoga, and you know, I've had people I had one guy, I remember he'd had a hip replacement and his wife dragged him along, and he was due to have another hip replacement. And having done yoga, not only did his operated hip improve enormously, but the one he was waiting to have surgery on, he decided to ditch the surgery, you know. And so I think flexibility as well as strength, you know, moving a joint through all its inches is really, really good, but done very carefully and very slowly and very respectfully. So
Yeah.
sorry, I just wanted to add that.
No, I completely agree with you. But flexibility is not the prime. Strength is the prime. You know,
Oh, yeah.
Yeah.
Yeah. Yeah, I agree
Flexibility
with that.
comes second. Flexibility comes second. Yeah.
Right. So I think our final question, David, would you like to ask your last question?
Yeah, it's not so much a question, it's something I need to share that will give people hope, actually. This time last year, my pain started in my left hip, and within a month to 2 months, I could only walk about 200 yards. I could cycle no problem, but I could hardly walk, maybe a quarter of a mile at the best before it gave me pain. Since then, so in the last 10 months, this is what I've done. I've been doing bespoke exercises the physio gave me to strengthen the muscles around my hip. I do that twice a week, every week. I do a lot of cycling, a little bit of walking. I've had random sessions of bowing therapy for realignment, and I also use a PEMF machine, which is pulsed electromagnetic frequency therapy. Now, one of the things that is allegedly supposed to do is regenerate tissue, regenerate cartilage, and promote stem cells. So I know the medical establishment says you cannot regenerate cartilage, but there's other evidence elsewhere, which is probably for another discussion, that says actually you can. So I just wanted to share that. So anyway, the point is now, a year later, I can now walk 2 to 3 miles with no problem. And the pain is decreased by about 60–70% when I'm walking. So I just get, you know, the odd twinge behind my knee, like a shooting pain, but they don't last long. But generally, I'm a lot better, and I'm walking a lot further than I ever thought I could without medical intervention and just doing natural stuff. So I just wanted to share that.
No, that's very kind of you to share that. A very inspirational story. I agree that your exercises has helped you. I disagree that the PEMF and the the Bowen therapy might have helped you. But you must understand, any therapist who inspires you is good.
Yeah.
Even your partner, your friend who says, you are amazing, you can do it, is a good therapist. So, you know, anyone who can guide you along, inspire you, motivate you is fine. So whether it be a Bowen therapist or a physiotherapist, doesn't matter, because they need to, you know, you need to help them. If you go to a doctor and he doesn't even smile at you, you're not going to get better. If you smile at a patient and say, oh, I have every faith in you, you can do it, then obviously, you know, you're likely to get better. Because I don't want people going and buying this PEMF, because, and any device has to have a randomized controlled trial. I'm sure all of you know about randomized controlled trials. You should have a placebo, and over and above the placebo, it should show that there is benefit. You must understand that patients, you know, the classical example is that 100 patients with back pain were given a blue tablet and said, you know, this will make your pain better. 70 of them got better because of this blue tablet. Then they were told, the 70 were told, actually, you were taking only a sugar tablet. It was nothing, there was no medicine in them. You know what 40 of the 70 said? Well, it might have been a sugar tablet, but please continue to give us because it made us better. The power of placebo, the power of the mind is amazing. You know, that is again in nociplastic pain. So, you know, I wake up in the morning, I look at my mirror, my face in the mirror and say, what a handsome man, another day. You know, the power of positive thinking is, you know, amazing. Sorry.
Thank you.
All right. Well, I think, George, there appear to be no further questions. So I think we all would like to thank you so much for your time this evening.
Thank you very
for
much.
your inspirational talk, for giving us lots of information, and for backing that up with the research that your talk is based on.
Thank you.
To give us ideas and then to spend time with us all answering questions. So thank you very much indeed for your time, but also thank you to everybody else who has signed in and come, for your interest, your questions, and we look forward to a further session with you on a different subject, and you might know we shall all be there to hear what you have to say.
Sure. Thank you, Sarah. Thank you
so
for the
much.
opportunity. And I also take the point of thanking Amanda for giving, you know, Sarah and Amanda gave me this opportunity to speak. Thank you so much.
Not at all. So on behalf of the College of Medicine, thank you to all of you.
Thank you.
Thank
Bye.
you.
Thank you.
Have
Bye.
a lovely evening.
Thank you.
Thank you.
Bye.
Bye.
Thank you. Thank you.
Thank you.
Bye.